Alan?
Good afternoon. My name is Alan Benson, and I am with the African American Initiative. The African American Initiative is a group of community stakeholders that are looking at policy efforts that affect directly and indirectly the African American community. Today, we're going to be discussing the COVID-19 and the disparities within the African American community. We have a group of dynamic speakers that's going to present today. They are Dr. Ricky Jones, Dr. Faye Jones, Dr. Wayne Tuckson, Dr. Brandy Pryor, as well as Dr. Wayne Tuckson. State Senator Gerald NEAL, he will be interviewing the candidates. Today, we're going to be on Facebook Live as well as WLOU. So please send in any comments or questions via Facebook Live, or you may dial 502-776-WLOU. This could not happen without the collaborative efforts of our community stakeholders and co-conveners. I would like to thank the AAI team as well as the community. So with that said, I'm going to turn it over to Senator Gerald NEAL. Thank you.
Thank you, Alan. Thank you very much. And thank you to the viewers that have had an opportunity to join us this evening. We have a dynamic panel, as we've indicated. And I guess the framework for what we're talking about is, some people would say that being a person of color in America is bad for your health. In the US, the health disparities between Blacks and whites run deep. And I could go into the details, but we have a panel of experts here that can actually address these issues. I'd like to introduce them at this time. We have with us Dr. Wayne Tuckson. Wayne Tuckson is a medical doctor, a graduate of Howard University. He has served as a research and clinical fellow in the Department of Colon and Rectal Surgery at the Cleveland Clinic Foundation. Returned to Howard University Hospital as an assistant professor, as well as an associate professor in the Department of Surgery. He also did that at the University of Louisville and is now a member of the physicians group. He has a particular interest in issues related to disparity in health status of minorities, particularly that of African Americans. We also have with us Dr. Brandy Kelly Pryor. She serves as Senior Director of Programs at the Humana Foundation, where she oversees the foundation's strategy, research, and impact for its $14 million grants portfolio. She previously was the inaugural professor to be jointly appointed as the Director of the Center for Health Equity, a division within the Louisville Metro Jefferson County Department of Public Health and Wellness, and as an assistant professor with the University of Louisville School of Public Health and Information Science. Additionally, we're pleased to have Dr. V. Faye Jones. Dr. Faye Jones holds a master's degree in public health and a doctorate in epidemiology from the University of Louisville. She has participated in executive leadership for academic medicines at Drexel University, among other skill-enhancing initiatives. She serves as the Associate Dean for Minority and Rural Affairs in the School of Medicine, the University of Louisville. As Associate Vice President of the state's Area Health Education Centers, Dr. Jones works with all 4 schools on the Health Science Center campus, including dentistry, medicine, nursing, and public health and information sciences. And last but not least, we have with us Dr. Ricky Jones. Dr. Ricky Jones serves as the professor and chair of African American Studies at the University of Louisville. He has served in that capacity collectively for some 24 years. He was the second African American to receive a PhD in political science from the University of Kentucky, where he specialized in political philosophy and comparative politics. He has also served as a National Science Foundation Fellow at the University of Nebraska, Lincoln. Jones is the author of many books and articles and has emerged as a strong public scholar, doing especially innovative work on American race, politics, leadership, and male identity. So I'd like to welcome our guests today. We're looking forward to what I know will be a very informative exchange here. And where we're going to go about this is this. We're going to ask each to give a presentation in order. for the length of time that you so choose, up to about 10 minutes, and then we'll come back into an interview format and see if we can mesh out some of the issues that arise. So we'll begin with Dr. Wayne Tuckson. Dr. Tuckson, tell us exactly where we are as it relates to our health and disparities and related issues in this community and beyond.
Sure, Senator Neal, thank you very much. It's a privilege to have the opportunity to be a part of this panel. And hopefully I'll be able to address that topic with those slides that we have here, and we'll try to see if we can't go through this. What we want to try to do here is talk a little bit about COVID-19 and what its impact has been on the African-American community. There are a couple ways of looking at COVID-19 really, in terms of what its impact has been on everybody. I don't mean just African-Americans, but the entire United States. There's something called the infection fatality rate. And what this is the number of people who have the condition, in this case, COVID-19, depending upon how the diagnosis was made, either through using the nasal swab, which is the nucleic acid test, which is by far and away the best test, or whether or not somebody went and did serum antibodies to get the test done. So these are people who clinically have the infection. And when you look at that, we'll know then what is the fatality rate? How many people die if you know that they actually had the problem? And for COVID-19, the overall infection fatality rate is about 1.3%. When you compare that to what the seasonal flu is, the seasonal influenza, it's usually only about 0.1%. So a lot of times you hear people say, well, isn't COVID-19 really just the flu? No, it's not. It's a lot more aggressive. And you can really see this in this when we talk about case fatality rate. And the difference between case fatality rate and infected fatality rate, and when we talk about case fatality rate, this is a definitive diagnosis based upon using a nucleic acid study, which is by far and away the best way to tell. And so we know these people definitely have, as opposed to suspected of having a COVID-19. And the number of these people who actually die, who get the infection and then die, is about 6%. Why is that important? Because again, overall, if you look at the same thing for influenza, as we talked about a moment ago, it's only 0.1%. So we see that people who get COVID-19 have a much higher risk of dying from the disease than people just have simple flu. Now, let's compare that to what went on in 1918 with the Spanish flu. Overall, 2.5% of the world's population died from the Spanish flu. In the United States, the numbers range anywhere from 0.7 to 2%. Now, importantly, of African Americans, we had a mortality rate of anywhere from 1 to 3%, whereas for whites, it tended to be a little lower, between 1 to 2%. And a lot of this had to do with where we were living in the rural South at the time, kind of acted as some socially distancing. Now, American Public Media Research Lab put together a couple of studies, a couple of reports rather. And one of these led to a graph here, which is looking at that long green line, which you see all the way headed out, is actually the number of deaths per 100,000 people for African Americans. Light green is Asians, Latinos are in that little teal color, white is in the little bluish thing, and gray is just everybody, all races. If you see, we by far and away have the highest risk of dying, or have the highest incidence of dying from COVID-19 of any other ethnic group. And this again can be borne out by looking at this slide. 13% of the US population is African Americans, yet we account for almost 27% of the overall deaths due to COVID-19. Interestingly enough, 17 states really have the highest percentage. Only 8 states that did not report their data at all. But of the states that are reporting, 17 have a way disproportionate number of African Americans having COVID-19, dying from COVID-19 than anybody else. Anywhere from up from 10 to 33% of the population of people who are dying were in fact African Americans. Chicago is a travesty. 50% of the cases that were COVID-19 in Chicago were African American. And 70% of the people who died in Chicago from COVID-19 were African American, even though African Americans only make up 30% of the population. More importantly, when you isolate it down to 5 neighborhoods in south side of Chicago are where the highest incidences of COVID-19 deaths were taking place. And of course, these were all African-American neighborhoods. Similarly, when you look back in Louisiana, about 71% of the deaths due to COVID-19 were African-Americans, even though African-Americans only make up a third of the state's population. So what we're seeing is a much higher burden of not only the incidents, but in particularly the mortality from COVID-19 within the African-American community. Across the country, though, if you look at where are the highest rates of death, they're in those counties that have predominantly African-American people, as opposed to predominantly white people. Almost a 6-fold increase in the rate of deaths in Black counties versus in white. So clearly something's going on. So what are some of the factors that are influencing this high mortality rate? Well, number one, high housing density. You got a lot of people living together in close proximity to one another. Poor access to healthy foods. People tend to eat poorly. They tend to be in worse nutritional health. Consequently, that affects their overall general health, which also can impact on the patient's immune system, their ability to respond to infections such as with COVID-19. These also people tend to be at the low end of social economic status, and I think there'll be other discussions later talking about what impact that has on health overall. But the other thing we know about people who have an increased risk for dying of COVID-19, they tend to be older. Hypertension tends to be more common in this group. Coronary artery disease is more common. Diabetes lessens the ability of the body to respond to this immuno challenge, and they tend to cause them to die. Obesity also impacts the immune system. Asthma, we know that COVID-19 is a primarily respiratory disease. If the lungs are already damaged because of the asthma, then when you get something like COVID-19, that further increases this patient's risk for dying. And now there's some discussion. A buddy of mine, Vivian Griffith, was kind enough to send me some information about vitamin D deficiency. And there are others who are talking about this. You know, being African-American, we tend to not absorb as much vitamin D because that's how you get it through the sun. And there's a question about the role of vitamin D in our immune functions. This is something that's going to be looked at a little bit later. How do we prevent the development or catching COVID-19? Well, number one, good hand hygiene, washing our hands, soap and water, or using an alcohol-based prep whenever necessary. Face mask when we go out. Yes, it is absurd to see somebody out there walking nowadays without a mask. So people should wear their masks to try to protect themselves from passing on something and also from trying to catch it. Then, of course, you get to the problem of social distancing. We do need to maintain this 6 feet thing. But if you're living in a neighborhood where everybody's close together, how are you going to maintain that social distancing? This is an interesting quote. I find it very interesting. It says, monetary implications in living environments must be dealt with. Limited job opportunities usually mean crowded living conditions and thus acceleration of the spread of communicable diseases. I think this is a rather profound statement, and it kind of predicts the problem we're into right now as far as COVID-19. The problem is, this was said in 1949. This is taken from an article talking about Negro health as a serious problem in the Louisville Courier Journal here in Kentucky. And it was said by Mr. J. Harvey Kearns, who at that time was Assistant Director of the Department of Research for the National Urban League. In other words, the problems that we are facing with are not new. These are issues we've been dealing with for many, many decades. So the question comes down to, when we're talking about COVID-19, and its impact on the African-American community, we're seeing the culmination of a series of problems. When we look at the poor health statistics that African-Americans are burdened with, a lot of this has to do with accessibility to the healthcare services, the quality of the healthcare services which we're receiving, and also the quality of the care when people are providing these things to us. It's a problem. In 1985, there was a report developed by Margaret Hexler, who was then the Secretary of Health and Human Services. And her report dealt with why was this a huge discrepancy on survival of African Americans from cancer, cardiovascular disease, cerebral vascular disease, diabetes, and also as far as accidents. And what it turned out, she identified several factors, none of which have we addressed yet. The same study was almost replicated by the Institute of Medicine in 2010, in which they again talked about the unequal burden, talking about African Americans bearing a greater share of healthcare problems than anybody else. Again, the problem was none of the issues or the solutions to these problems were addressed. I think this is something that we'll be getting into later on. So when talking about COVID-19, it ain't new. We've been here. We've been battling this for a long time. And I'll also throw this in. There was polio many years ago, back in the 20s and the 30s. African Americans, again, bore a disproportionate burden from polio, just like we're seeing. So it seems like every time there's a pandemic, we seem to have the biggest problem. So having said that, our problems are not new. The solutions need to be implemented, and I look forward to any questions that you may have coming down the road, Senator NEAL. And thank you all very much for the opportunity of speaking.
Well, thank you very much. We'll now go to Dr. Pryor. Dr. Pryor, so I know you've done a lot of work in the field of equity and so forth, and your job enhances that in your area of study. What can you tell us about equity? You have to unmute.
Thank you so much for that, Senator NEAL, and Dr. Tuxton for going through the numbers, because when we talk about what is health equity, or when we're talking about equity in general, it's really just an evaluation tool that's used, and that is to measure a gap. The larger the gap, the larger the inequities. The smaller the gap, the higher levels of equity that we have in our community. So when we're talking about health equity, we're taking health outcomes that we see in a community, such as the asthma, diabetes, obesity rates that were just talked about, and more specifically right now, COVID-19 and the infection rate as well as the mortality rate of COVID-19. And we're looking at what does that look like in proportion to the population in which you're talking about. And so when we see right now that the proportion of the population, when we have 70%, numbers like 70% in cities that have 20% African-American populations, then what we're really saying is that there is a disproportionate effect on African-Americans. And that disproportionate effect is avoidable, and it's based off of unfair and unjust policies and practices that have gotten us to that point. So, for instance, we're hearing about asthma, and knowing that neighborhood development, housing, environmental quality are all aspects of asthma. So we take asthma and think about the imagery of a tree. Asthma is the health outcome. That's the symptom. That's what we would consider in health equity, the leaves of the tree. The actual root or the cause of that health outcome would be environmental quality, housing, neighborhood development. And how has there been disinvestment in those particular communities to where now we see a disproportionate, not only impact of as it relates to asthma related deaths, but now that's having a disproportionate impact on how people are able to overcome the symptoms, the respiratory effects of COVID-19. So we have to think all the way down to the roots. In health equity or in equity in general, I like to ask the question of why 5 times, so that we're not just getting to a conversation about people washing their hands more or the personal responsibility that someone needs to take to solve a particular problem, but how has the ecosystem really impacted them, not only in that moment, which we might call the actual where you live, work, or play, but how has that impacted them over the course of their lifetime? So when we're talking about health and we look at the impacts that it has on an individual, that impact starts while they're in the womb, right? So if we're talking about African-American communities, we can't divorce the conversation about diabetes and heart disease and asthma, for that matter, of what was the health of their mother, or what was the health of the community in which they were actually being formed in, or while they were in gestation. And the stress of being in America, particularly at this time in our communities, when we see stress from not only the ability or the need to have to go outside of the home and work. So with work from home options that a lot of people have during COVID-19, it is not really that feasible for those who are working low income jobs for them to work from home. There might not be the opportunity from a technology standpoint or even the actual job itself. So there's a disproportionate impact on the stress that it has of going outside of the home and knowing that, you know, you might be faced with the particular options of being in contact with the virus. And how do you keep yourself safe during that time, as well as how do you keep your family members that you might be living with during that time. That's one aspect of it. Another aspect of it is the continuous stress. I always like to say, just like Dr. Tuxson said, that we were dealing with these issues before the virus. There was an epidemic before the pandemic struck. And that epidemic was in the US in terms of how do we really know that the foundation of these health outcomes, asthma is a health outcome, the root cause of that health outcome would be the housing, the environmental quality, the job status, the educational status. How did that come to be? I like to think of that as the soil of the tree. And so the soil of the tree is all of those inequities that have been baked into the United States or into our society. So everything from racism to sexism to even the way that we structure our economic status and class system in this particular country. We might call that classism or capitalism. Those are really important foundations for us to shift. So there's a terminology that we use when we're talking about health equity, and those are the social determinants of health. Oftentimes we think of those social determinants of health as social needs. And social needs are how do we meet someone's housing need? How do we meet someone's food need at the time? Those are acute needs that we are talking about and that you will hear, particularly during this time of the health and economic crisis that we're in right now. That's meeting a social need. But for us to really challenge the social determinant of health, which is the food system, which is the housing system in our country, we need to actually shift the foundation of this country and talk about the policies and practices which have gotten us here over the course of the past 400 years, really, in terms of thinking about how wealth has been built in this country and how even race, knowing that this is not a biological factor, what is happening with African Americans and the mortality rate that's being experienced from COVID-19 or any other virus or disease outcome that there might be in a community. That is not biologically, there is no difference. There may not be as much of a difference, I should say, between me and a white male in the US with red hair, as compared to with me and someone else who is from South Africa that might have my same skin tone, right? So race is our social construct, and I'm sure we'll get more into talking about that, but it is just really really important to understand in this conversation about equity is that we are measuring a gap as it relates to how particular populations have been treated within our particular society and how that has complicated and constricted our life and death outcomes. It really comes down to a life and death outcome. And those gaps that we are creating for some communities that have lower life expectancies, if we take here in Louisville, knowing that there's a 12.6 life expectancy gap between some zip codes, primarily between those that are largely predominantly African American communities and those who are in white communities in one city. If we take that understanding, then oftentimes people will turn a blind eye to that and say, well, that is not my neighborhood, or that is not my social background or any other social identity. If I don't have that social identity, I might not want to really shift, as we were talking about before, the soil of that tree or the root of that tree. But what we know about health equity and what we know about inequities is as we widen the gap, then it gets worse for those who are at the top as well. So we are driving down our life expectancies in the United States with all of the resources that the United States has. We should have the largest or the highest health outcomes and highest life expectancy out of any developing nation in the world. And we sit now at 46 because of how wide our gap is of inequities. And that's based off of our institutional arrangements. That's based off of us wanting to meet social needs of particular people and not really wanting to truly address the soil of our community or our social determinants of health or social determinants of equity. Thank you.
Well, thank you, Dr. Pryor. And Dr. Jones, if I turn to you at this point, what's the role does a physician play combating the disparities that we're hearing about currently with COVID-19, but in addressing health disparities in general.
Thank you for allowing me to be a part of this session. I've enjoyed hearing what the other two speakers, and I just want to continue to expand on what they've been saying before. Now, this pandemic has dramatically exposed the connection between the social determinants of health and our physical health. It brings into focus what we've known for decades. Where we live, work, and play determines our health outcomes. Many of our underrepresented and our underserved communities report disproportionately high rates of chronic diseases, like Dr. Tutson had said, hypertension, asthma, and diabetes, all dramatically affects the outcomes and mortality of COVID-19 that we are seeing with the data. It tells us that health disparities are driven by unequal access to health providers, particularly primary care, like internal medicine, pediatrics, and family medicine practitioners, and healthcare access. Additionally, employment opportunities may limit insurance choices, which can affect treatment plans, as well as who are able to work from home and who are not. The housing options, like it was discussed before, factor into health with many multi-generation families living together, which can result in increased risk of exposure. The condition of the unit may also pose a threat in health in some cases. As a pediatrician, one of my focuses is on the issue of unequal educational opportunities, which is correlated with future health outcomes. But for healthcare in general, we have to be concerned about health literacy. Health literacy is the degree to which individuals have the capacity to obtain, process, and understand basic health information needed to make appropriate health decisions. Nearly a third of adults have low health literacy skills. Transportation also influences healthcare utilizations. Question we should be asking is there a convenient bus route for our patients, residents to our offices? Is parking readily available and affordable? What is our late policies, particularly when it relates to unforeseen, uncontrollable events? Their environment also affects our health. Think about the air and the water quality. The amount of pollution in the air has a major impact on respiratory diseases in our patients. In addition, we are all familiar with the stories of the water issues, particularly like lead in the water in some of our major cities. We should also consider our patients' access to their physical environment. Are there parks or gyms close by? Are there walkable sidewalks or safety concerns? When we try to tell families what they need to be doing to better their health. So we make these proclamations, but they may not be very practical. Finally, having accessibility to healthy foods should be a given, but in many neighborhoods, it's a challenge. So, there's opportunities for us to make sure that those resources are available of the closest food banks, any places that give those things out for families. Now, while only 10% of health is directly affected by the clinical care, as a clinician, there are many areas we need and can impact. Now, Black physicians make up only 5% of the total active physicians in the US, and 10% of nurses in the US identify as Black. We know that having the health professionals that look like you and who can relate to similar experiences can improve overall health of our patients. However, these numbers don't represent the overall percentage in the US of 13% of the population who identify as Black. We need to be grooming and supporting our next generation of healthcare professionals beginning in elementary school. Starting with K through 12, let's empower our students in science, technology, engineering, and math, the STEM areas, to better prepare them to enter in the healthcare field. We need to be funding pipeline programs to expose students to the many different fields available in the profession. I know when I decided I wanted to be a pediatrician, I didn't know about all the healthcare fields. I didn't know a lot about that. So we need to be able to expose people, our kids, to this. In higher education, we need to incorporate community engagement and policy discussions throughout their education so that this generation can be very informed and make those changes that needs to happen. In the professional schools, we need to augment the curriculum by integrating the impact of structural racism on communities and how this translates into the health disparities, inequities that we see today. We can't be afraid to have real in-depth discussions of race and racism within that curriculum. And we also need to have transparent data that routinely includes demographics. It needs to be the norm, not the exception. And also building respect and long-term partnerships with community are a necessity. It's essential that we examine the concept of implicit bias. Implicit bias refers to the attitudes or stereotypes that affects our understanding, actions, and decisions in an unconscious manner. We all have biases, that's part of life, but we know that it can affect medical decision-making related to treatment recommendations. Medical personnel needs to understand and receive training on how bias can lessen the quality of the patient-doctor communication and result in medical mistrust, which is still very problematic in this community and many others. It strains both the confidence and reliance on information that's received. This brings up the history of the Tuskegee syphilis study and the legacy of Henrietta Lacks with the HeLa cells. In this current environment of COVID-19, we need to understand how our history and structural racism affects decisions today. For example, let's consider who is tested and where testing sites are located. How do we educate different communities? Who is involved in research? How will treatments be distributed? How do we perform telehealth when available resources are so unbalanced? And how do we address the mental health services to communities that are already at risk for stress secondary to racism? Another one that's getting a lot of attention is when we have a vaccine available, how can we ensure that it's distributed equitably? All of these issues have the potential to increase the divide that is currently there within our communities. When we disregard the weight of health disparities, not only does it directly affect the population paying the price, but the whole community pays. According to the Kaiser Family Foundation, disparities amount to approximately $93 billion in excess medical care costs and $42 billion per year in lost productivity and premature deaths. Now, I want to go back to what I was saying before. This pandemic has clearly exposed to the disparities in our communities across the nation. If we fail to act now, it will only widen. We have to think both short and long term and push for fundamental lasting changes. As we move forward, we need to strive for health equity by infusing health in all policies using an equity lens. But I want to close with a quote from Dr. King. Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. We should do better, and with deliberate transparency and collaborative partnerships, we can do better. Turn it back over.
Well, thank you, Dr. Jones. I appreciate that, and a litany of things that can be done or should be done in order to deal with questions of disparities. Now we come to Dr. Ricky Jones, no relations. Put this into context here. What we've just heard here, what does that mean? Where does that come from? Give us some framework to understand what's going on here.
Certainly to all of my brothers and sisters in arms, the other Dr. Jones, Dr. Pryor, my surgeon, Dr. Tuckson, my great brother from Howard, and certainly to you, Senator NEAL, thank you for bringing these people together and bringing the community together to have a discussion about this. I think it's very, very important that we understand whenever we have these discussions, it's easy for us to just talk about education or just talk about health or just talk about an election or just talk about homelessness or just talk about any myriad of issues that disproportionately affect Black people. We see Black people being impacted negatively, literally from the cradle to the grave, where we have higher infant mortality rates in this country, but we live shorter lives. We are disproportionately undereducated, disproportionately underemployed or unemployed. We Black men make up only 5 to 6% of the population of this country, but almost half of the jail and prison population of this country. So we understand whenever we see something that's going on around Black communities with COVID-19 or anything else, what we're really speaking of all the time is the fact that racism itself is a global pandemic and has been a global pandemic and a national pandemic, certainly, that has impacted Black people to a greater degree than almost any other population in this country. It has literally killed millions upon millions of people psychically, spiritually, mentally, and physically, and that's still going on. And what we have to do, I think, so I don't belabor this point because all of the brothers and sisters who spoke before me started to touch on it, we're really having a political discussion. And what I mean by politics is the definition, not just of simply going out to vote, but the definition coming from this great political scientist, Harold Laswell, who said politics is the process that decides who gets what, when, where, and how. I'll say that again, the process that decides who gets what, when, where, and how. So the question for us is, how do we build the political influence, power, and muscle to have a greater amount of sway in the decision-making process that impacts Black men, women, and children in this country as we move forward, as we continue to suffer through the global pandemic of racism, which COVID-19 once again just illuminates that we're dealing with. But anybody who's paid attention to any degree has known that Black people have been going through it for as long as we've been on these shores. And while it's gotten a bit better in some ways, I think we have to understand, to use another health analogy, racism is like cancer. It's smart, it adapts, it morphs, it adjusts to the environment that it's in. So you can't use the same medicine on a cancer patient twice because the cancer will learn. And racism is the same way. So just because it doesn't look like it did in 1820 or 1920, it doesn't mean that we're not dealing with it in 2020. And it is literally snatching people's lives right in front of our eyes. And so we need to be very diligent and very brave, as Dr. Faye Jones said, and not cower away from the things we need to do to try to push back against that.
Well, thank you for that. Let me say that it just appears to me that there's some interesting things that can be laid out here that puts this in sort of, it's a take on what you just said, quite frankly. African Americans own approximately 1/10 of the wealth of white Americans. In 2016, the median wealth for non-retired Black households 25 years old and older was less than 1/10 that of similarly situated white households. The Black-white wealth gap has not recovered from the Great Recession. In 2007, immediately before the Great Recession, the median wealth of Blacks was nearly 14% that of whites. Black households have fewer and are in greater need of personal savings than their white counterparts. I could go on and on and on about that particular subject matter, but the fact of the matter is that we're still in this, and the question is, how do you change that dynamic? So I want to raise that question. I'm going to throw it back to you. I've heard the word, and we both all know, or all of us speaking, we're dealing with, in one aspect, structural racism. You know, how do you do that? I think you gave one, build up political muscle, but exactly what do you have to do, or do you have thoughts on that? I'm talking to Ricky Jones.
Okay, I think the first thing, all of this really becomes a question of policy, and at multiple levels, it's a question of policy. So when we're talking about elementary schools, or middle schools or high school, we need to make sure that we have administrators in those schools who are going to impact the curriculums of those schools. We need to make sure that we have school superintendents in whatever space that we're in that cares about Black children. Building Up Faith started to talk about educational outcomes that literally start in junior kindergarten. I mean, we have jails, which are largely held by private shareholders now in this country, and they're predicting prison populations starting with 3rd grade test scores. And quite often that is delivering Black children into these. I really do think that, no, certainly you don't need to hear this, Senator NEAL, but the Democratic Party needs to be challenged at this point, because the Black community is disproportionately loyal to the Democratic Party. And we need some politicians who are not just going to come into Black communities or Black churches every 2, 4, or 6 years for votes, but who are going to pay attention to policy issues specific to African-American communities across the country. And so I think, a number of other things can certainly go on. We can go to every corporation, every university, and make sure that the professors and the administrators are taken to task on whether or not they're paying attention to the needs of African-American students, African-American workers. We can even go to places like the NFL, a league that has over 70 to 80% Black players, but only 3 Black coaches and 1 Black general manager. So we see these discrepancies across the board. There's nowhere we don't see them. And so I think the Black people have to be very, very diligent and not rest on our laurels because things have gotten a little bit better.
I think you make a good point there. I think it's when the COVID came up, a number of people responded like this was something new and something isolated and something specific. But clearly in this presentation, and what we all really know historically is tremendously documented, the disparity throughout, rooted in slavery, enslavement, all the way through to today, Jim Crow and so forth. Dr. Tuckson, you talked about Louisiana and some of the other states. Can you bring that home to Kentucky and Louisville a little bit in terms of that impact? You got 50%, I believe it was, the ratio out of Chicago. What is it looking like in Louisville and in Kentucky?
We're anywhere from, right now, we're about 2 to 2.5 times what what we represent. So I think it is in Kentucky, we're about 8%. We're showing about 18% of we're 8% of the population in Kentucky. We're about 18% of the mortality rate here in Kentucky. So we clearly have the same discrepancy that everybody else is seeing. And quite frankly, you know, one would not be surprised by that when you look at the structure of our healthcare and all the other things that have gone on. I want to make one thing too to what the Dr. Ricky Jones said. You know, we talk about your third grade test scores being a predictive factor of whether or not a kid's going to get into, wind up going to jail or not. But more importantly, I think Faye Jones knows this probably better than I do. But when you look at people who get adequate prenatal care, but most importantly, the type of care that mothers should get and their children get immediately following delivery for those first 2 years, those who don't get the same standard of care have an increased risk of running the risk of being involved in the criminal justice system. Plus, they tend to have poor outcomes all the way. So when we talk about impacting how health impacts social determinants, not just social determinants impacting health, but kids who aren't getting adequate infant and early childhood care are running the risk for bad outcomes and also getting into that. To get back again to your point, you know, we have done a lot. We as African Americans have done a great deal as far as our care. I mentioned the polio thing because with polio, it was said that African Americans, or at that time they were saying Negroes, weren't getting polio, weren't going to get polio. We were denied that diagnosis. When I say denied, because it was clear to anybody who looked that African Americans were getting polio, but it was determined that they were genetically unable to develop polio. But as a consequence, African American physicians and nurses and other healthcare workers at the time were inadequately trained. In fact, one of the fellows, Dr. Chenault, who was an orthopedic surgeon, African American orthopedic surgeon, said he was ashamed of the fact that he didn't know how to do this. But more importantly, even when you look at what Franklin Roosevelt at his Warm Springs spa for developing one of the treatments for patients with polio, they excluded African Americans, yet they still had African Americans who were the primary givers of care in terms of rub downs, laundry services, keeping the place clean. They were there, but they wouldn't let any African Americans come in. And the last thing I'll say, and this again gets back to the health, to juxtaposition between health and social policy. The guy that was head of the American Polio Association, I apologize for not getting the exact name straight, he said the problem is that African Americans weren't being responsible enough to recognize when they had a problem and to seek out the care when the problem was there. They were relying upon, and I quote, old superstitious ways. Now, you're not letting people in the door, then you're going to turn around and blame them for not getting care. And I mention that only because in 1866, and then I'll be quiet after this, 1866, there was a meeting of African Americans, people from the Freedmen's Bureau, and those African Americans were churches and business leaders. What were they doing? They were there to get money for a hospital to care for sick and injured former slaves. And a guy from the Courier Journal was there and wrote an editorial talking about how these, Black folks should quit shucking and jiving and tend to business. This is 1 year after slavery, and Black folks are already trying to take responsibility for their own health care. So the pattern is there. So yes, sir, we do have a problem in Kentucky.
I think you can't overlook the fact that that structural piece again that's there. And then those who don't live that reality or have advantage from that reality existing will have a tendency to say, well, if they just did this, if they just did that, it's sort of like blaming the victim kind of situation. Dr. Faye Jones, could you expand on that, what Dr. Tuckson was talking about?
No, it's been throughout history that we have issues like this where we want to do something or that we have been criticized for trying to protect ourselves. And I want to go back to something related to what I said before with unconscious bias, implicit bias, how that affects the care of individuals. Like I said, we all have bias. There's no question about it. And one of the things I would recommend our audience to do is look at the Harvard implicit test. It gives, you can take it and see where your bias is in multiple different categories. But it makes such a difference in healthcare. There's been study after study that shows that that really affects the treatment people get. With Black people, they get less pain medication, get less so many other things. There was a study that was in 2016 that shows where this, how significant this is, done in a medical school and looking at bias and pain medication. And some of the myths that people had was that Black people have thicker skin, so they don't need much pain medication. Those kind of things. I know it's crazy that you would think that medical students, residents, people would think that Black folks have thicker skin, and so you don't get as much medication. All those stereotypes are out there, and it makes a difference in what happens to these folks. Something that Dr. Tupson was talking about as far as children. It is, if you look at a study, the ACE study, that Adverse Childhood study that came way back, probably it's been several decades, but it's just recently getting more and more attention. It shows that things that happen to kids when they're young affects their health and older age kids, when they're adults. And they were looking at, when they first did the study, it was mainly looking at white folks. But then they did a Philadelphia ACE study where they actually put some of the figures or some of the issues that Black populations have had more so than other populations, and showed that their ACE scores was so much higher and had so much more chronic diseases as a result of some of these ACE studies. There was a correlation there that all the stress, all the events that happened to Black folks is such a major issue for their health in the long run. And it kind of not explains it totally, but it does put a factor in there of the things that the African-American population has gone through throughout history.
Well, you're reinforcing what the theme that I hear going through this conversation. I want to turn to Dr. Pryor here. I know that you have done a lot of work in this equity area. And in fact, you were very much involved in the health equity report development. I think it was 2017 report. Mm-hmm. Could you tell us a little bit about the focus of that report and how it came about and some of the things that it determined came out of that, and see where that goes?
Absolutely. So the Center for Health Equity here in Louisville is the oldest municipal department in anywhere in the country that has a municipal department that is dedicated to discovering and talking about health equity. So Dr. Adewale Troutman, when he was the health department director for Louisville Metro Public Health and Wellness, was very critical, not only as a public health scholar, but here locally, to talk about there is a connection that we're seeing between life expectancy in African Americans, as well as other communities of color, and what their actual opportunities are for those health outcomes. Not in terms of, are you choosing the healthy behaviors, but are the healthy behaviors even available for you to choose? And so the Center for Health Equity was developed out of that. And I had the honor and the privilege of being able to be the director for the Center for Health Equity, not only during its going into its 10th year, but also in developing the 2017 Health Equity Report, which is the third iteration of health equity reports that have been done over time. But I came in, obviously, with not only really critical lens of how do we use critical race theory to have a conversation about what's happening in the life course of individuals in our country, but also having a really intentional conversation about, and what are we going to do about it, right? So I think we've known, as we've heard through all of what everybody is sharing here, is we have known this. And actually there were studies done by doctors as early as before the Civil War to say that racism and slavery was having an impact on the health of African Americans. There's a tall tale, John Henry, if you all are familiar with John Henry and him battling against the steel drill. And so John Henry, as saying, you know, he can do it. And so we're talking, you know, Dr. Tuxen has talked about even right after the Civil War, and it's this conversation about African Americans who are doing for themselves during this period of Reconstruction, but yet and still are being in some ways blamed for the health outcomes that are happening in a community after just, you know, leaving a period of bondage within this country. So it's really interesting because John Henryism, this health theory, it talks about how despite the fact that African Americans, and so that's, you know, using the same name of the tall tale, but there was a real man named John Henry. And we see this with most recently, you know, the head of Kaiser Permanente passing away. And so we've earlier in proportion to those who have that same social status in society. So African American men, African American women who have maternal mortality rates that are higher than that of their white female counterparts who have not graduated high school and they have advanced degrees. And if we're using education as some proxy in terms of your health status, we see that that is not the case for African Americans. And so John Henryism talks about this, the impact of racism on one's health and how that is still, when you control for everything, race matters. And so that's what the Health Equity Report over the multiple iterations of it has been, is not only to talk about zip code, which is very critical, and zip code does matter in terms of where you're living and your health outcomes, but it really has more of an intersectional lens to talk about, let's look at this from an aspect of race and gender. There's still so much further that the Health Equity Report can go and that it will go over the years. I would encourage everyone to check it out and read it, all 179 pages of it, but it is healthequityreport.com. That's HEALTHEQUITYREPORT.com. And the Center for Health Equity is still doing the amazing work. We need more data infrastructure and more funding that's going into public health so that we actually know exactly where do we need to target these interventions when pandemics hit, right? It's when, because we know that COVID-19 is just one of multiple that will still continue to come.
Well, I have to tell you that I'm happy to report to you, you probably already know that equity shop down there at Metro is still going strong. In fact, I've engaged with T. Gonzalez, who I believe is the head of that now. T. Gonzalez and individual out of Stephen Stack's office in Frankfurt. And we're working in revamping a health equities policy piece for the Kentucky General Assembly to consider to deal with health equity type things. So I have to give a real shout out to that equity piece. And I'm just pleased to know that you were involved in the initiation of that.
Can I ask a question?
Also this report. Yes.
Yeah. But it's I think it's interesting if one looks at the Health Equity Report, it's almost a blueprint for the things I think we need to do. But more importantly, it's not just a blueprint for what we need to do. I think it is a blueprint for the majority population in terms of what, again, I'm gonna go back to a 1946 paper that, you know, thing that came out in the Courier Journal. They were talking about how African Americans had a 2 to 3 time mortality rate from tuberculosis. They had increased almost 2 or 3 times from diabetes, even in 46. And it was one of the things. But they came back and said the problem was that African Americans were living in confined areas where at that time you had almost 20 people, up to 20 people living in 2 to 3 room homes. So you had a lot of disease just being passed around, not to mention the crowded conditions of the community. So they did a survey and they asked 110 white that's all they were at University of Louisville then, 110 white University of Louisville students. Number one, what do you think about the conditions in which they're living in? 93 of them said, this is terrible. That's clearly a problem. You need to do something about it. 83 of them said, but I understand, and a white landlord should not be forced to rent to an African American. And then finally they asked, 82 of them said in response to the question, would you like to have an African American living in your neighborhood? They all said no. So what does this tell you? They know what the problem is. They're not interested in the solution. Yeah. You know, and that's the thing. We keep coming back. We're regurgitating what the problem is. I don't know. Do you wait on these people? No, I think we have to move forward about it. But nonetheless, the thing about Dr. Kelly Pryor's report.
We all know each other.
Yeah, it is. But here are the things we need to attack. And that's the thing about the Hexa report. Here's the roadmap on what we do to go about this. But the thing is, you get this lip service from a certain segment of our community. Yes, we understand you got a problem, but it's almost like the letter from a Birmingham jail. Slow down, just don't go too fast. Things will take care of itself. So when you talk about what, Faye said, man, we ain't got to wait for the next pandemic. If you wait for the next pandemic, we're going to be talking about the numbers we're talking about now. We have got to act now to address the problem.
Let me jump in on that for just a second,
please, go right ahead.
Wayne, because I think it's really important that we acknowledge a few things. One, this ethic of white saviorism, like we're in, Mississippi burning or something like that, where white people are going to swoop in and proactively save Black people. There is no historical evidence that that is going to happen. I mean, as Frederick Douglass said, power concedes nothing without a demand. It never has, it never will. So we've never seen an instance in the history of this country where white people in mass have proactively shown any type of humane concern for Black people. And so the question on the heels of that is, what do you do? Now, to Brandy's point, when you talk about CEOs, Black professionals dying sooner than whites who are similarly situated, that answer is pretty clear. It is a question of stress, of Black stress, of the tax that is taken upon all of us by simply being Black. You think it ain't hell to navigate the University of Louisville, even though you have a PhD and you Black? You still have to navigate that. I'm sure it's hell in every hospital, every professional organization that Brandy is in, that Faye's in, that Wayne is in. It's hell. I'm sure it's hell on you, Gerald, to try to put any type of policy forward in the state capitol that is specifically speaking to Black suffering, because you're going to, one, have white people who don't give a damn, and you're going to have some of the Black politicians who's too scared to back you up. There is a cost, I think, for being Black and brave, right? So how can we come together and take care of one another and try to put things on the table and leverage that? That's 2. 3, there is some serious classism in the Black community that has to be spoken of. We got some Negroes who have done a little bit better than others, and they have forgotten about the masses. It's me, my foe, and no more. As long as they got their big house and 2.5 car garage, they cool. If we remember our history, we run back, since we have a history talk right now, back to the 1830s, when we had the Negro Convention movement to start. And the first president of the Negro Convention movement was Richard Allen, one of the principal founders of the AME Church, a Black radical by any stance. But these free Black people who were in the Negro Convention movement, even though they were not slaves, many of them had never been slaves, were consistently concerned with slavery, because they understood that as long as slavery existed, they themselves could be delivered back into slavery, as well as the humane concern for brothers and sisters and Black children who were trapped in that institution anyway. So if we don't get some type of collective ethic as Black folk, and we need to start right here where we live, and we in Louisville, you fight where you are. And so we can't come together and try to connect with brothers and sisters who are on the ground and suffering, who we usually don't connect with at all in our bourgeois circles, then all is lost. And if we don't get some bravery in the circles where we are, it's a sin and a shame for any of us anywhere to see systems that are dominated by people who do not look like us in small areas and allow people who look like us to be attacked by those systems, right? So wherever you are, whether it's a university, a company, or down at the garbage collection place, if you see Black people being mistreated, then stand with them. That's very, very important. And I think that'll lower that stress a little bit, because we will then feel like at least I got some brothers and sisters who are gonna stand with me, and a few white people who remember John Brown, even though the majority of them don't. I'll be quiet now.
Thank you for those insights. Let this time, let's take a couple of questions from some folks that sent them in, and then we'll come back and anybody can respond unless it's directed specifically to you, if you will. Alan, what do you have for me? Why don't you give us a couple of questions?
Okay. First of all, we all have seen these decorative face masks throughout the community, and we know there's a shortage of the official or certified mask to protect us from COVID-19. What are the risks of not having a certified COVID-19 mask, like such as not having an N95 mask? What are some of the risks?
Dying?
I'll jump on in there, man.
Well, we know that.
The whole thing about masks has kind of evolved. If you remember in the beginning, it was said that people don't need to wear a mask unless you have some symptoms or something. But a lot of that was because we know that a lot of the masks that we see out there really don't stop a lot of viral particles, except for the N95 mask, which it does. Now, what is the thing about masks? Masks other than the N95 are good to wear because, number one, if we have something, it at least minimizes or mitigates the spread of viral particles coming out. Remember, this stuff is aerosol based. So if you cough, you sneeze, you talk, material is going to be blown out there. If you have a mask on, at least it cuts down on the volume or the concentration of this material that's coming out. That's number one. So by wearing a mask, we're minimizing what we're passing on to somebody else. It may not necessarily do a lot if somebody has COVID-19 and comes around us, that mask, other than an N95 mask, which of course will work, but the others may not. But it does help mitigate and it decreases the risk. Number two thing about the mask, it reminds us that there's a problem going on. And I think this is one of the reasons why some people don't want to wear their mask, because people sometimes don't want to be reminded that there's a problem. We want to think that, okay, I've done my 4 weeks of quarantine, everything is back to normal. I can get out there and in the sun and sunbathe or do whatever it is I want to, and I got to wear this mask. No, we have to wear the mask. There is still a problem out there. So that kind of reminds, and then the other thing about it, if we're all out there wearing a mask, we know then that each one of us psychologically is saying, to get back to what Ricky said, I got your back. I am with you in solidarity. We are functioning as one community to protect one another. Not only are we going to do the social isolation or the social distancing, but because I'm wearing a mask, I'm trying to do the very best that I can. It's almost like the story of the hummingbird and the forest fire. There's a fire in the forest. There's a fire in the forest, and all the the elephants, lions, zebras, all the other big animals are sitting there watching. There's one little hummingbird that's flying back and forth from the lake to the fire and just spitting this little bit of water on there. And the elephant said, "Man, what are you doing? You're just wasting your time." She said, I may not be doing much, but I'm doing all that I can do," which is the same thing about this mask. I may not be doing everything, but I'm doing something to mitigate this risk. And this is what we need to do. So I hope that, so the question is, do I need to wear a mask? Yes. If it's one of those fancy cloth masks that somebody has out there, great, wear it. If you want to kick it up a notch, put a little slip inside. My wife makes these masks. You put a little slit in there, put a little filter in there, or a little piece of paper or something that'll help block some of the other material. Even better still. So yes, wear the mask, wear the mask, wear the mask.
Okay. Yes, Ricky Jones, Dr. Jones.
Yeah.
You were talking about the community and some of the historical racism that has occurred and so forth. And you and I both know that around election time, or even between that time, there's a huge push for voting and so forth and getting people registered to vote. But some of us see that voting is just the tip of the iceberg. It's really about the policy. Do you feel collectively as a community that we really have a true understanding of the effects of policies? And if not, what could we do to bring about a better understanding of how policies affect the African American community and how we can drive that into really advocating change in the community in terms of policies.
Yeah, well, I don't think we do have a very good understanding of policy, not just the policy process, but we really don't have an understanding of what we need collectively as Black communities to aid our community. Again, from what we really seem disturbingly, I said from the cradle to the grave, but when we listen to the other Dr. Jones and Dr. Tuckson, it actually starts in vitro, right? I mean, in the mother's wombs, the way we're being impacted. But I think we're in a dangerous place right now. We can impact the future of public policy in this country. We can't do it through the Republican Party right now. The Republican Party is basically rolling like, as we should say in the projects of Atlanta, like guerrilla pimps. They're political gangsters. They're telling Black people in word and deed, we don't give a damn about you. But what the Democratic Party is doing by and large is even more insidious. They're basically coming through, getting votes, but then not even mentioning our names. They're handling us like we're mistresses to be visited at 1 or 2 o'clock in the morning, and then they hang with somebody else during the day. We are the Democrats' most loyal constituency. Well over 90% of Black people vote for Democrats, but Democrats very rarely talk about public policy that specifically targets Black people. And this is one of those very dangerous moments of diversity and inclusion and things of that nature. So when you talk about diversity, I had a colleague tell me when I mentioned something about specifically about Black people at the university where I am, and he said it's dangerous if we talk about diversity along a racial binary. And I'm Black, I'm like, to hell with that. Everybody needs somebody who's gonna advocate, who's gonna proselytize for their group. So I think Black people need to let go of this talk about we're not a monolithic society. The way we're suffering, we damn well better be monolithic when it comes to reparations. We better be monolithic when it comes to economic betterment in our communities. We better be monolithic when it comes to violence against our people by agents of the state. Where we see Black men literally being hunted in the streets like dogs in Georgia, shot down, and there's some question about whether or not the men who deputize themselves as distributors of justice should be punished by the law. There's a problem if a sister right here in Louisville, Kentucky can be killed in her sleep, and people are really wondering if anything's gonna be done, and the man who is trying to protect her because he loved her is being charged with murder. We better be monolithic when we talk about these things. We see a Black child in Cleveland, Ohio killed within seconds of police arriving. We better be monolithic when we do not have curricula in schools from K through 12 all the way through higher ed where our people even exist in those curricula. So if we're not monolithic in those things, and we're not pushing some of these politicians who coming through primaries to speak to Black people, I say to hell with all of y'all. You better give us a candidate that's gonna say something about Black people when you get in office. Otherwise, how about we leave you alone and see what happens if Black people don't come out and vote at all, and can you beat the Republicans then? And I think white America is showing them without the people of color, the Democrats are done. And so we need to leverage that and move forward.
I want to make out a point. You made a very good point there because it really tees up exactly why AAI exists. One of the things that we observed back in what came about in 2010 was that just what you just said. We do a lot of programs, and programs are important, of course, but we weren't dealing with policy. And that's what AAI is about, policy. So we're talking about homing in specifically on those policy questions or issues that impact the Black community. But your point's well taken, I can tell you that.
Yeah,
Doctor, I'm sorry.
I'm just saying that it is really up to Black people. You know, yeah. I firmly believe it is up to Black people to advocate for Black people. Nobody's going to advocate for us the way that we will. And some folks say, well, that's a racist thing to say. That's not a racist thing to say. That's not saying I hate white people or anything like that. That's not the point at all. Yeah. I'm simply saying that it is up to us to advocate for us because we've seen that nobody else is going to do that. And if we see that, then I think we're done.
Well, I think you're absolutely right. Now, Dr. Faye Jones, Dr. Jones, the other Jones, can you tell us more? Can you tell us more about the research on implicit bias in healthcare and how that factors into this?
Okay, we kind of talked about it a little bit before. The research is very strong. It's been going on for years on implicit bias, how that makes people feel, basically how you treat a patient, how you treat somebody that's different than yourself. And we see this all the time in the field, that if you go to people or you congregate to people that's more like yourself. So you have to be trained got first off made aware that this exists, because a lot of people deny, okay, I'm not biased, because they automatically associate it, okay, I'm not racist. That is not the way to think of it. Bias is a normal function. It's what you do with that bias. It makes all the difference in the world. It will make a difference on what type of treatment that's happening, whether you realize it or not. And it is affected by the Institute of Medicine. They talked about this in one of their reports, how much bias affects healthcare for Black patients, for any minority patients. So we have to be able to accept that it's there, because that's the first step. Accept that it's there, and then go about seeing how we can mitigate it. So when you make that decision on whatever that treatment is, whatever your interaction is, you have to say, okay, is this decision a decision I would make for someone else that's someone like me? Or is this a decision that maybe I need to rethink of what I'm doing instead? So it is really, really, really strong evidence that that is one of the major things that's causing health disparities. I mean, I just think about some of the experiences that I've had when you go into a room, or when I've been a patient, and you just feel it. You just feel like they've made a decision about who you are, what you are, without even knowing anything about you, just because of the way you look. And that's not acceptable. That is not acceptable. So I know, Dr. Brandy, you've had some experience with unconscious bias in your work, not maybe directed at you, but on how this has affected some of the decisions and even some of the policy decisions that's come through. Because this happens not just in healthcare, but in any decisions that we make. When we're talking about policies, when we're in a group, who's getting to make those decisions? What's in their experience is causing those decisions to be made? It's so prevalent that it's kind of like insidious. We don't even realize it's happening, so we have to think about it as we go forward.
Although Dr. Jones, this implicit bias piece in a larger context, not just in healthcare, how do you see that manifesting itself? Give us a little context on that.
Who, me?
Yes. You.
Man, I don't even call it implicit bias or unconscious bias. I just call it damn racism. I think that's what it is. And I think what's really problematic for us all, to be very serious, structural racism is constructed in such a way that if you are a Black person who speaks against that system that is already in place, one, there's a neat trick in white America that if you speak to white racism and how it affects Black people, they'll very quickly call you a racist. You know, they was talking about reverse racism and foolishness like that. But also what's really, really scary, because we're so far behind when you talk about being in positions of influence and power, that in most of these structures, if you stand up against those structures, you're shot through a process where people who don't look like you are making decisions about your fate and your punishment if you remain in that place. They can make it very, very uncomfortable for you or ruin you. We've seen Black people ruin up and down the line. That's why, you know, I'm really hard. I used to be really, really hard on people who are afraid, and on Uncle Toms and folks like that. And I've tried to grant them a little bit of grace because I understand the system that creates them. Even though I think they're dangerous and they're co-conspirators in Black oppression, I understand why they do what they do, because they're simply trying to protect themselves and stay safe and fit in. Unfortunately, though, that's feeding the rest of us to the dogs. So all this bias stuff, I think the white power structures are much more open to moderate sensibilities of people who have bowed to the politics of respectability than they are Black people who challenge those systems. And if Black people do challenge those systems, they try to isolate them or ruin them. And we see it every day. And we have to be sure that instead of seeing that ruination as an opportunity for us to slide into those people's positions, that we try to take care of those brothers and sisters as best we can. So I don't think they're unconscious about what the hell they're doing. I think they're very, very conscious about it. And then they just say, now what y'all gonna do? since we've done it to y'all, and we got to figure out how to respond.
I don't think there's any doubt about that. Dr. Pryor, implicit bias.
Yes, I mean, like both Dr. Jones are saying, it is very rooted in all that we do, you know, in every place that we are. It has, I think it's really important that we talk about this from an intersectional understanding as well. So, you know, thinking about community activists in the spaces that we're in, how often are we able to bring community members who are closest to the issue? In health equity, we say those who are closest to the issue have the solution to the problem, but it always still trickles down from talking about respectability politics, you know, oh, here's the brown person with the PhD. Here is the brown person that comes in with, you know, all of the letters behind them, or the right clothing, or even the right enunciation, you know,
You ain't like the rest of those Negroes, right?
Exactly. It's like, oh, you speak so well, or you're so articulate, you know, and
Right.
how so many times we, those of us who might garner that type of identity will also receive it without speaking up and saying, no, that is not okay. And there needs to be someone else at the table. Thinking about age in terms of how age also plays into that dynamic, in terms of who gets to speak for the situation that's closest to them. When we talk about decarceration in this country, why do we not have those who are formerly incarcerated folks, or those who are incarcerated, also finding ways to pipe them in? You know, if there's one thing that COVID-19 has taught us, it is all of the ways in which we have pushed back of including people, including the most marginalized in situations. We were able to turn that around in a day for those of us who, you know, needed to start to work from home, or those types of understandings. Angela Glover Blackwell, who used to lead Policy Link out in California, came up with this concept of the curb cut effect. And so thinking about, you know, when we see that curb cut in society, when I talk about policies, I always talk about it from the standpoint of thinking about those who are most marginalized. If we just have them at the center of our conversation, you know, we have this implicit association that we do with everything, but how do we push ourselves, taking that Harvard implicit association test, how do we push ourselves to say, okay, I'm aware and I'm cognizant of what my biases are. I am okay with recognizing that it is okay to have them. But as someone who has power in my community, whether that be in the seat that I sit, whether that be a police officer in a community, whether that be a mayor who has a bully pulpit, you know, how am I going to use whatever association that is implicit to me to push past all of that and say, okay, I'm going to bring that person in. And it might be a struggle for me to even hear, but when I'm able to do that, when we're able to bring those who are most marginalized, then we create benefits for us all. And that is just, you know, it really racks my brain in terms of thinking about those who are in power are working against their best interest, right? Because if they wanted to work with their interest in mind, then we wouldn't be having a conversation about racism. We wouldn't be having a conversation about how racism and classism intersect, or how we are trying to get to and out of our communities, but rather how we are ingratiating each other in terms of making the best world possible. And I came of, you know, I'm of that generation. I've came of the movement that another world is possible. So I'm a hope enthusiast. I believe it every single day. That is why I fight in this fight against racism, because I believe that we will be possible to overcome it. But at the same time, it's so frustrating, right? It's like, don't work against your own interest.
We do all the time.
Dr. Tuckson, I know you have something to say here. Before you do, I'm gonna see if Alan has another question from a caller.
Yes, we all know in every situation such as this pandemic, there's going to be some type of aftermath or change that's going to occur. With that, and this question is for all of you all, what type of impact you think this pandemic, once we get through this, how it's going to affect our healthcare system, as well as the health, you know, the access for health for African Americans, and just the overall system, United States or globally?
Let's start with Dr. Tuckson.
That's really, and I really appreciate that question. Clearly, the first off, the number one change is going to be the way in which we practice medicine is going to change. Dr. Pryor alluded to it with talking about someone who's working at home. A lot more healthcare is going to be telemedicine. So this idea of someone's going to have to take off the afternoon to come in to see a physician or a healthcare worker and get a 15-20 minute look and then go back home, that's going to die away. It's going to be more like we're doing right now, where we're interfacing. If you can do this, you can have a visit with most physicians at doing this very same process. That's number one. Number two, the absurdity of our insurance system is completely, I mean, if there was anybody other than the guy who runs United Healthcare, Anthem, you take whatever one you want to, who still thinks this is the way we have to go, they're wrong. We're going to have to come to either a universal healthcare or a Medicare for all or something else. And this concept of people worrying about, well, I don't want to have to give and pay for health insurance. Well, you see what happens when you don't pay for healthcare insurance, health insurance. Someone else is going to have to pick it up. The bill for this pandemic is going to be huge. And just because, and people who didn't pay into it are going to, I'm not going to say they're going to get away scot-free, but the rest of us are going to be paying a whole lot for this thing. So we've seen clearly the return on investment of having just a managed Medicaid program is going to be so great that it will offset the cost that we're going to put into. In the beginning, it's going to cost, make no mistake. But after about 4 or 5 years, the return on investment is going to be so great that we'll see the benefits, just like we started seeing under Bashir 1 before the devil came in. I mean, and just wiped away the whole thing. I mean, that was just, if you want to see what happens when everybody has health care, look at the quality of care of health of people under Bashir 1. Look at the quality of care on the people and whatever the guy's name was. It just, you can see the difference. So that's going to be the next thing that's going to happen to it. Next is going to be this idea of we're going to have more people in between the physician and the patient who are going to be out there in the community, checking on people to see how they're doing. You call them community health workers if you want to, whatever name you want. But that's going to take on a much bigger role for us. And then the last thing is because we're going to see about the cost of pharmaceuticals is going to have to be addressed. Because when you look at these drugs, make no mistake, remdesivir, yeah, they talk about they're going to give away, we're going to give away 1 million of these pills. But you're talking about 300 million people in the United States alone who potentially going to be buying this, not to mention worldwide. No, they ain't giving away nothing. There's going to be a price to pay. And the question is, can people afford the cost of medications to keep healthy? And then, of course, the other things we need to do and preventative to keep people from getting sick in the first place. So I see that. I don't know, Faye, how do you see it?
Oh, I totally agree with everything that you said. But another thing that I think that's going to be, hopefully will be changing too, is that we'll understand how much the social determinants of health affects our health. I mean, we say it all the time. We say it and been saying it, but this just really, really shows it. So I'm hoping that will actually translate into the educational part of it as well, within our system, within our educational systems, within the health professions, so that we will understand what part public health in general plays in medicine. And I know that sounds crazy, but there's people that still want to separate the practice of medicine from public health, and you can't. It is so intertwined. And this will hopefully put a fire under folks that has even any doubt. And we've talked about that 10% or 5% of physicians are Black, 10% of nurses. Hopefully this will be an impetus that we will diversify the healthcare workforce more, because we have stayed stagnant on this issue for decades, at least the last 2 decades, 3 decades, that we really haven't increased that. This should be an impetus that we have to put more resources into our programs that will hopefully inspire our next generation to be more diverse in the healthcare fields.
Can I add something else to that though? I think the other thing that's going to come about this is we have people in the C-suite and people in government offices, except for the present company accepted, of course. But they have essentially told a 40 to 45% of our population, you are disposable people. Your sole function is to make my life function. That's it. And what do and we've even given them a wonderful name. We have called them essential workers. Now, if that ain't the biggest load of crap that I've ever heard in my life, it's an insult. Essential worker. All of a sudden now the truck driver is an essential worker. By the way, I am not downing any job. No, these jobs are important. But we tell them you're essential, but we're not going to do anything to protect you. We're going to do absolutely nothing to protect you. And also, by the way, we're not going to pay you a living wage. So that's a different ballgame. We're going to tell the person working at the meat plant, because it's more important for me to have my T-bone steak than it is for you to be able to go home at the end of the day feeling healthy. These are disposable people. So hopefully, and I believe, though the majority of them are minority, they're either African-American, Latino, or new immigrants to the country. But for those who wear the red hat, I hope that they come to see that the red hat leader really doesn't care about them. His only interest, and the people in the C-suite and people in government positions, only interested in making the economy flow. What can you do? And the only example I got of that was back in the days, before 1865, and then, the sharecroppers thing that occurred after that. I mean, I don't know of any other better example. So that's the other thing I think that's going to have to change. And that's going to impact healthcare also.
But Wayne, very quickly before we get back to the senator, very quickly here, everything that you and Faye and Brandy, I mean, the medical folk have been talking about, when we talk about changes in healthcare, we talk about universal healthcare, Medicare for all, however you want to call it, shifting the system. We talk about pharmaceutical companies making money hand over fist by exploiting folk. And then your last very, very cogent point about having a reasonable, livable wage, talking about reasonable minimum wage in this country. Those are public policy decisions that were really being spoken to by only two presidential candidates, Elizabeth Warren and Bernie Sanders, neither of whom Black people supported. Black folk went out and caped for Joe Biden, who is more of a status quo politician than anything else. So that's why I say we gotta have some really, really serious conversations in our community about the politicians that we are delivering to office on the local, state, and national level. It ain't enough that he was Barack Obama's boy, because let me tell you something else. It ain't like Barack was out there going hard for Black folk either.
Well, with that being said, I want to thank each and every one of our panelists. This has been a very piercing discussion at times, but also a very informative discussion and a very frank discussion. And those of us at AAI really appreciate that. It's going to feed into what we have to do next. And this was part one. We're going to part two. We're going to delve deeper into this. And each of you are invited to participate in other aspects of what we're going to do, depending on what your inclination is. But we deeply appreciate you taking the time, your expertise, and sharing it with our listening, viewing audience here. I do want to say a couple of things. This is going to, of course, be on the AAI page, and it's going to, other folks can visit that later on, and they can see that. We're also going to put it up on YouTube, so those who don't have Facebook can do that. In about 2 weeks, we're going to go to our part two. We'll be announcing that pretty soon. And lastly, I want to get to our co-conveners. Our co-conveners have been fantastic. We have 27 co-conveners. Our plan is to bring them closer into this kind of discussion, and Ricky Jones, that policy piece, grabbing a hold of that, and maybe being a little more incisive about it, but certainly getting on the same page and making it happen. I think that's a good cogent point. I think that's something that comes out of this. So again, I want to thank you. I'm going to turn this back over to Alan, our moderator, to close us out.
Hey, thank you, Senator, for what you did, because you brought all this together, man. Outstanding job.
Thank you.
Thank you. Thank you. I'd like to thank each and every one of you all for participating. We had a lot of people to give their opinions, and we apologize for not answering all our questions. But this is, as what Senator NEAL stated, this is going to be a continuation. If you are interested in participating with AAI, that is the African American Initiative, please give me a call. My number is 502-767-6878. Call or send me a text, and we will go from there. Again, thank you to everyone. Thank you to the co-conveners, and go in peace, go in love, and have a great evening. Thank you.
Thank you very much.
Take it easy, family.
Bye.
Good.